Uh, this particular session is dedicated to all the scientists and basic researchers who kept searching for a needle in haystack. We know that it's very difficult to find a needle in haystack. And if you think of all the scientists who have worked in hard, you will be surprised to know that there are about 13 Nobel Prizes awarded to scientists who devoted their part of their careers for cholesterol research. If you go for the statistics, you'll be surprised to know that more than 50% of the coronary disease associated deaths are before the age of 50, and 25% of the mortal infarctions occur before the age of 40. Just before a few days, even the new status came, there's almost 35 to 40% of the MI before the age of 40. What has been observed over the large number of patients over a large studies, that small reduction in LDL-C achieved at a very early age and maintained for a large period of time will bring about marked reduction in the ASCVD events. If the patient has a cholesterol levels, LDL cholesterol levels of 200 milligram every year, then the same ASCVD event would occur right at the age of 35 years. And if we achieve the LDL to 70 milligram per year, then we expect the ASCVD to be at 100 years. This is what Eugene Dowdall has suggested from this figure, and that is what is the aim of the medical science.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
So let us start with today's topic. This topic, in fact, is been suggested by some of the viewers of the last session, where we discuss about the lipid profile interpretation. And I thought that it's worthwhile discussing because we did not discuss many of the questions in the QA session at that time about the therapy. So I am going to repeat many of the slides, initial slides, for the benefit of those who are joining for the first time. And it's again remain the in continuation of what we are going to discuss further. So stay with us, and I have to suggest that there is no conflict of interest for this particular session because I'm going to discuss many of the drugs with their brand names because these are the only ones which are available in our Indian market, and it's only for the information of the members that I'm going to quote them name. I neither endorse nor suggest anything about that. Uh, this particular session is dedicated to all the scientists and basic researchers who kept searching for a needle in haystack. We know that it's very difficult to find a needle in haystack. And if we think of all the scientists who have worked in hard, you will be surprised to know that there are about 13 Nobel Prizes awarded to scientists who devoted their part of their careers for cholesterol research. And one of the duo, and this was the Joseph Goldstein and Michael Brown. They, for the first time, found out LDL receptors way back in 1974. They were awarded the Nobel Prize for Physiology and Medicine in 1985 for the discovery of LDL receptors. And up till now, we have been thinking, even as a medical student, we have been thinking that why are we discussing about the rare diseases or genetic diseases? But having gone through the story of LDL receptors and the statin lowering therapy, I am convinced that these are the diseases which the nature is sending us for finding out the cure by the scientist. So one of the diseases was familial hypercholesteremia. The homozygous hypercholesteremia sufferers are having the very high LDL levels because of the genetic mutation of the ApoB lipoprotein, and that is why they have accumulation of large quantity of LDL, and that is why they develop the lipid abnormality and cardiovascular and other events in their prime age of their life. And this is how the Michael Brown and Joseph Goldstein found out the LDL receptors, and then they say that rest is the history. So what I'm going to discuss about something that I have talked earlier also about why we need to know lipid levels, what are the lipids, what are the lipoproteins. Cholesterol levels is a new concept which has now been picked up. Last time Dr. Mahesh Shah was a cardiologist who has discussed in detail about the many of the medicines, and we are going to repeat some of them. But it was also a very excellent talk, and I would request the readers to go through his talk also in our replay sessions. And about the lipid lowering drugs, this is more of a, we can say, a clinical pharmacology type of talk, and we'll be talking less about the trials, not to bore you with the statistics. So first, why should we need to know the lipid levels? Because we know that the atherosclerotic cardiovascular disease is the main cause of death worldwide. And one of the important cause of the ASCVD is the dyslipidemia. And as much as 79% of the Indians have one lipid abnormality as against 53% of the US populations. If you go for the statistics, you'll be surprised to know that more than 50% of the coronary artery disease-associated deaths are before the age of 50, and 25% of the myocardial infarctions occur before the age of 40. Just before few days, even the new statistics came, there's almost 35 to 40% of the MI before the age of 40. And what is more disturbing is that the Indians develop atherosclerotic cardiovascular disease at a much younger age. They're very malignant disease and they're very high fatality rate. The dyslipidemia causing ASCVD was first detected in the 2004 Internists study, which was a study in the 52 countries across the globe. And even at that time, it was known before 20 years that median age of myocardial infarction is 53 years in Indians as against 58 in the other years. And now we see almost a decade earlier. And one of the important outcome of this trial was that dyslipidemia has the highest population attributable risk for CVD. All in all, what we want to stress is that the dyslipidemia is number one culprit as far as the ASCVD are concerned. So that brings the question of what are lipids. Lipids is very interchangeably used with all these terms, but in fact, it's a family of fatty compounds that includes triglycerides, phospholipids, and sterols. The most important sterol is cholesterol. Again, these are not interchangeable. You cannot use triglyceride and phospholipid and sterol for the same lipid. They are different, their functions are different, and their composition different, their absorption is different, their way of degradation is different in the body. So three important lipids: triglycerides, phospholipids, and cholesterol. Out of these, the triglycerides are the fatty acids which have got three chains of fatty acids with a glycerol molecule, while phospholipids have two fatty acids chain with a glycerol backbone and a phosphate molecule. And this is the one which makes it different as far as their characteristics are concerned, that we'll be seeing in the another slides also. And cholesterols are one of the very important backbone for our cellular functions as well as many of the hormone productions. So all three together we can say are important for the energy and energy storage, that is triglycerides. Cell structure is maintained mainly by the phospholipids. The phospholipids make a bilayer, and these are all called the cell membranes, which was earlier used to be called plasma membrane. Every cell is covered by the membrane, which is called a cell membrane or a plasma membrane, and that is mainly chiefly contributed by the phospholipids. There are few unacidified cholesterols, there are proteins attached on the cell membrane, but mainly it is phospholipids, and this phospholipids has the characteristic of amphiphilic. What we mean by amphiphilic is they are hydrophilic as well as hydrophobic, and we'll see again in the later slides the importance of this. So this is very important to know that the triglycerides are for the energy storage, phospholipids for the cell structures, and sterols for the cell structures as well as the hormone productions, our sex hormones, estrogen, vitamin D, corticosteroids. They are all made up of cholesterol. The cholesterol is very, very important and one of the main topic of discussion today, obviously. So it's a 27 carbon compound and the formula is C27H46O. It has got three important parts: the central sterol nucleus, which has 4 hydrocarbons, as you can see in the slide. Then there is a hydroxyl group OH at one end, and there is a tail end which is by the hydrocarbon. All this makes it very, very interesting molecule. The hydrocarbon side chain is hydrophobic, and that is why, plus the sterol central nucleus together makes it insoluble in water. So cholesterol cannot be transported from the intestines where it is absorbed to the all parts through the blood circulations unless it is transported by some medium, and that is where the lipoproteins come. We can have cholesterol in our body from the food, right? As well as we also have the capacity to synthesize cholesterol in virtually every cells, but most importantly the liver. Liver contributes to almost 70% of the cholesterol that is in our body. But the cholesterol is something which cannot be degraded. It can only be converted to bile acids or it can be converted into different hormones, but it cannot go into the acetyl-CoA unit precursor, which are required for the energy source. That is why it's just not like triglycerides, which are the food source of main source of energy. It's mainly a source for the cell structure as well as for the hormones. Now, what are lipoproteins? Lipoproteins are the proteins which act as the lipid transport system because, as we have said, the triglycerides as well as the cholesterol, they are insoluble in blood, but they need to be carried away from the site of synthesis or site of absorption to the different tissues for their functions. So, what is done that the triglycerides and cholesterols are packaged within the lipoproteins. The lipoproteins have a phospholipid layer which few cholesterols and the apolipoproteins on their surface, and they carry inside the core of the lipoprotein, they carry cholesterol and triglycerides. And this phospholipid membrane is the one which has got, as I said, amphiphilic structure. So it is, their head is hydrophilic and the tail is hydrophobic. So the fatty acids, they are all inside, while the hydrophilic is the one part which is protecting outside, and that is how the cholesterols and triglycerides are being transported. Very important to understand that why we need to take more care of cholesterol than the other structures, because if we see the lipoprotein composition, then we can say the chylomicron has got 80% triglycerides. They are mainly seen when they are being taken up from the intestines to the from the breast border of the intestine, they are taken into the lymphatic channels into the blood circulation directly. While VLDL, LDL, HDL have got a different composition of cholesterol, triglycerides, phospholipids, and the protein. So, as you can see that LDL has got the maximum amount of cholesterol. LDL has got maximum amount of cholesterol, which is 50%, while HDL has maximum percentage of proteins, and the VLDS has got a maximum percentage of triglycerides. So, LDL is the chief contributor or the storage for the cholesterol in the body, LDL cholesterol. If you see the density of all these molecules, it reduces from chylomicron to HDL, increases from chylomicron to HDL. So, HDL, as the name suggests, is high density lipoproteins. Its density is 1.06. As against that, the chylomicron are lighter. That's why they always float, right? And when it comes to the size of the molecule, the size is most with chylomicron. The density is less, but the size is more. Chylomicrons are a bigger molecule, 75 nanometer. 1 nanometer is 1 billionth of a meter. So, VLDL is 30 nanometer, LDL is 25 nanometer, and HDL is the smallest, 5 nanometer. Why we need to know is that anything more than 75 nanometer, they cannot enter the intima. It is only the small molecules of 30, 25, 5 millimeter, they can enter the intima and start the process of atherosclerosis. And that is why we need to take care of those particular substances which are smaller in size. When it comes to important parameters that we see in a lipid profile is that we look for total cholesterol, triglycerides, HDL cholesterol, LDL cholesterol, VLDL cholesterol, and non-HDL cholesterol. What is most important, as it is highlighted, is the LDL cholesterol and non-HDL cholesterol. LDL cholesterol should preferably less than 100 milligram per deciliter, and non-HDL is less than 130 nanogram per liter. Triglycerides, if it is a fasting sample, less than 150 should be the optimum, but if it is a non-fasting sample, at 25 milligram, that is 175 milligram. So, ideally, all persons should have LDL cholesterol of less than 100, but as we'll see further, we'll see that those who are at a higher risk of ASCVD would require to bring down the cholesterol to less than 70, and in fact, very high level need to be brought down to 30 or 50. So what are the benefits of lipid lowering therapy? What has been observed over the large number of patients over a large studies, that small reduction in LDL-C achieved at a very early age and maintained for a large uh, period of time will bring about marked reduction in the ASCVD events, then becoming more aggressive when something happens, right, at a later age. And we know that the LDL lowering therapy is now very effective, very safe, and practically inexpensive in the common drugs that we use. Another important concept of cholesterol years, the atherosclerotic burden is expressed as cholesterol years or LDL cholesterol years. And this is measured, what it reflects is the cumulative amount of LDL that is person is exposed to or his arteries are exposed to. So if there is a cholesterol threshold of 7,000 milligram, it has been observed that if the cholesterol threshold is achieved by 7,000 milligram, the person is likely to develop the ASCVD event at particular point of time. How do we translate into the figures? If the person has an average LDL cholesterol of 100 for every year, and then the cumulative cholesterol load would be 7,000 at the age of 70 years. So he's expected to develop an episode of ASCVD at 70 years. But if the patient has a cholesterol levels, LDL cholesterol levels of 200 milligram every year, then the same ASCVD event would occur right at the age of 35 years. And if we achieve the LDL to 70 milligram per year, then we expect the ASCVD to be at 100 years. This is what Eugene Dowdall has suggested from this figure, and that is what is the aim of the medical science. Our Lipid Association of India has also come out with the updated guidelines, and these guidelines are not in the form of any calculators. They have just come out with an ASCVD risk algorithm, which is based on the categories that they have categorized the ASCVD risk groups as low risk group, moderate risk groups, high risk groups, very high risk groups, and extremely high risks, which depends on they have given different tables for the presence or absence of risk factors, whether it's an age or tobacco or diabetes or family history of premature ASCVD, or risk factors like what is their coronary calcium score, what is their LPA level, and all this. There are different lists of this. It has already been highlighted by Dr. Mehra and it's available in LAI. So we are not going to discuss, it's little exhaustive. Come back to the pharmacology of lipid lowering therapy, that is the topic of the day mainly. And we know there are list of drugs for LDL cholesterol lowering drugs as well as the triglycerides lowering drugs. The LDL lowering drugs starts with statin, ezetimibe, bemperoic acid, PCSK9 inhibitors, older drugs, niacin, bile acid sequestrants, and very new drugs still not available in Indian market except for by the import license, lopetamide and mipomersan. One of the viewers did ask about this mipomersan at that point of last time. So, and that incident prompted me to take this talk. So, triglyceride lowering drugs are fibrates, fish oils as a combination of eicosapentaenoic acid or dicohexanoic acid, or alone EPA or eicosapentol ethyl or saroglitazar. But we are not going to discuss the triglycerides lowering drugs as well as the niacin bile acid sequestrants, because the rest of the drugs itself will consume good time. So if we start with all the drugs, where are their drugs are the mechanism of actions mainly either liver, intestines, or in the blood or in the peripheral cells. The peripheral cells drugs are still in the pipeline in the research at this point of time. So the most of the important drugs that bring down the cholesterol levels substantially are in the liver. So liver is the site of action for these drugs. The most important drug statin, second is bempedoic acid, and PCSK inhibitors. They all work in the liver. The second group of drugs which work at the intestine level are the ezetimibe and bile acid sequestrants. We don't use bile acid sequestrants these days because of the side effects, and we have better drugs. But ezetimibe is the main drug which works in the intestines. There is also a drug which works in the liver as well as in the plasma, that is at the apoprotein B levels, that is lomitapid. And there is drugs which works for the triglycerides are all working in the liver, that is fibrates, these fish oils as well as saroglitazar. So coming to the most important drug of statin, The statin is the drug which we are going to discuss in more detail, because that's what we have to know, because that's a drug we start, and most of the times we achieve at least the LDL levels to at least below 100 with most of the optimum doses of statins, and they are reasonably safe. But when it comes to statins, we should know which are the drugs, how do we select, which is, do we go for a natural statin or a synthetic one? Do we need to prefer hydrophilic or a lipophilic statin? What is the efficacy of different statins? What are the safety of different statins? What is the cost, and what are the drug-drug interactions? So we'll be, for statins, definitely we need to discuss this in all these headings. So first come to statins, whether they are natural statins or synthetic statins. The natural statins were the one which were available in the earlier generations, that are produced from the fungi, but they are less potent weight by weight wise. So lovastatin, simvastatin, and pravastatin practically are not used in our setup, but we still find many patients coming from the Western counterparts who still are receiving, many of them are receiving simvastatin. So we need to know something about them if they happen to come with these drugs and have some side effects. But synthetic statins are one which are produced synthetically, and they are very potent. The all important drugs that we use, atorvastatin, rosuvastatin, they are all synthetic, and so is pitavastatin. Pitavastatin is the most potent weight by weight. That is why the dose is 2 and 4 milligram. This is an important aspect of the statins. Some statins are hydrophilic, that means they are water soluble, the ease of renal excretion, but they have more liver toxicity. Rosuvastatin and pitavastatins are hydrophilic, but atorvastatin, simvastatin, lovastatin, and pravastatin are lipophilic. So for practical purposes, rosuvastatin and pitavastatin is hydrophilic, while atorvastatin is lipophilic. Lipophilic is the one which has faster absorption and wide distribution, but it also has got more muscle toxicity. So this is where it helps. If the patient has some liver impairment, I would switch from hydrophilic to lipophilic. If the patient has muscle toxicities, it's better that we prefer to the drugs which are hydrophilic. Efficacy of statins, well, there is nothing much to choose as far as if you use the right dose. So at equipotent doses, all statins have similar efficacy. It is proved in more than one studies, and for every 39 milligram, that comes to 1 millimole. Also, because practically for 40 milligram of LDL reductions, there is a reduction of the vascular events by as much as 21%. So which is quite a substantial degree of reduction with just 40 milligram of reduction of LDL, and this is true across most of the statins. But if it comes to the HMG-CoA reductase, which is the enzyme which blocks the synthesis of cholesterol, rosuvastatin has the highest activity, that is 51%. This is a very, very important slide worth looking at. We do say that 10 milligram of rosuvastatin is equivalent to 20 milligram of atorvastatin, or 20 milligram of atorvastatin is 10 milligram of rosuvastatin. Based on this particular studies, it has been shown that if you use 20 milligram of atorvastatin, it will bring down the LDL from the starting days to 43% of the baseline, and rosuvastatin bring down the same in 10 milligram. So that is how it is said that the rosuvastatin is twice the potent of atorvastatin. But what is important is that incremental dose does not bring about the same degree of reduction. In fact, it brings out hardly 5% to 6% of the dose reduction. So going from 10 to 20 milligram, you do not achieve much, and that is where the role of the other non-statin drugs come into play. But important thing is atorvastatin 20 milligram, rosuvastatin 10 milligram should be the starting dose if you want to bring down the cholesterol to 40% or more. And if you bring down to 40%, we need a higher dose, which is called a moderate to high dose of statins. All the evidence for trials for primary prevention, secondary prevention, acute coronary syndrome, all spectrum of coronary disease have shown the efficacy of statin across all molecules, across all indications, whether it is a pravastatin, simvastatin, atorvastatin, rosuvastatin, or lovastatins, and whether it is a primary, secondary, or an ACS trials, all have shown efficacy. Same is the stroke. Again, these slides we had shown last time that it is all drugs, statins are universally proven to be very effective, and they bring down the LDL and bring down the CV events. The next important part, the drug-drug interactions with the statins. The two important statins will be focusing, atorvastatin and rosuvastatins. And the two important metabolic pathways which would bring about the drug-drug interactions are CYP3A4 and CYP2C9. No need to worry about it. Just remember that rosuvastatin is the one which is not metabolized by CYP3A4, and that is why rosuvastatin has minimum drug-drug interactions when use statins and other drugs like calcium channel blockers or amiodarone or many other drugs. So importantly, if you have to use the older generations drugs like lovastatin or simvastatin, you have to be very careful while giving drugs like amiodarone or calcium channel blockers. Amongst calcium channel blockers, you have to be very careful with non-dihydropyridine types of calcium blockers with atorvastatin. The non-dihydrobilin, what I mean is diltiazem and verapamil. So when you use diltiazem and verapamil, if the patient is on atorvastatin, we should be a little careful about it. This is very, very important, and I'm sure everybody would be interested to know how safe are the statins. Statins are considered to be very, very safe, but still it's not without side effects. And it has been said, this is a very landmark paper in the Lancet which came in 2016, Interpretation of Evidence of Efficacy and Safety of Statin Therapy, which was a review article. And it mentioned that if you use atorvastatin in a moderate dose, 40 milligram, for 5 years in 10,000 patients, if you use moderately high dose statins for atorvastatin for 5 years in 10,000 persons, right, then you expect 5 cases of myopathy, out of which 1 may develop rhabdomyolysis. You may get 50 to 100 new cases of diabetes, and you may get 5 to 10 hemorrhagic strokes. So this is the statistics of statin-induced toxicities. It can produce myopathy, it can produce new onset diabetes, and it can produce hemorrhagic strokes. Though it prevents embolic strokes, it does have a very small risk of hemorrhagic stroke. We'll further elaborate this. What does this mean? When it comes to muscle-related toxicities, it is divided into myalgia, myopathy, and myositis. Myalgia is when the patient complains of pain, soreness of the muscles, but there is no rise in the creatine kinase or creatine phosphokinase. While myopathy and myositis, there will be definite elevations of the creatine kinase. The important factor to keep in mind about the muscle-related toxicities of statins are that people who are receiving a higher dose, people who are old, people who have an impaired renal or hepatic functions, or patients who are engaged in vigorous physical activities, and those who have vitamin D deficiency, they are likely to get the muscle toxicities more. So we have to keep this in mind when we prescribe, and if the patient complains of muscle pain or other symptoms. And in such cases, as discussed earlier, it's better to prefer a hydrophilic statin like rosuvastatin or pitavastatin against the atorvastatin that we commonly use, and we may get a lipophilic side effects. Another important concept that has been observed in these studies is that the patients who have got a negative feeling for this, which that's why it's mentioned Google Scholars, those who come by reading, net surfing, they are likely to have a negative feeling, and that is why they will get more symptoms. That is called a nocebo effect. Like placebo effect, which is a good effect of the drug, negative effect is called nocebo. So nocebo effect can explain some of the symptoms when we do not find any physical findings or any rise in CK or CPK or even liver enzymes, and the symptoms start coming on the very first or second day or third day. It's not likely to be the actual effect, but probably a nocebo effect. The statin-related myopathy symptoms are usually pain, tenderness, cramps, or weakness, and usually starts with leg muscles. Maybe it's because of the muscle, large bulk of the muscles that is, and it's usually worse after the exercise, and they do not resolve without discontinuance. So if the patient's symptoms disappear, probably it could have been a nocebo effect. And we have to stop the drugs if it's a genuine muscle-related toxicities, unless we take care of the other factors like vitamin D deficiency and all those things. If the symptoms resolve, then start with a lower dose or change statins. That is the standard thing that we do. And if the symptoms do not resolve within 2 weeks after stopping the statins, then we have to think of the other cause for muscle-related symptoms. That's very, very important. So once the patient has symptoms, which look like the statin-induced muscle symptoms like worse after exercise, or and they are not reducing after even 2 weeks of the off statin therapy, it's better that we look for some other cause of myopathy, maybe the endocrinal cause or some other drugs. And the last part is that if we have to give the statins and still the patient, we may start with a very small dose and that to an alternate therapy. It is mentioned as one of the last resort for patients who are statin intolerant. But nowadays, when you've got many non-statin therapy, it's better that we switch to non-statin therapy for the same. Statin-induced new onset diabetes has been highlighted after the Jupiter trial, which used rosuvastatin in a very high dose of 20 milligram. And but so in fact, it has been a class effect that statins does produce new onset diabetes, but the incidence is not more than 10% new onset diabetes on a very high dose for a sustained period of more than 2 years. There has been the study, but definitely the difference within the statins is not statistically significant. That means atorvastatin, rosuvastatin, not a big difference, but rosuvastatin was which picked up the new onset diabetes, and that is how it's perceived that rosuvastatin caused more impaired glucose and new onset diabetes. Patients who have got high body mass index, patients who are having pre-diabetes, and patients who are metabolic syndrome definitely have a very high risk of developing diabetes. And but the fact that the statins produce significant reductions in the cardiovascular events and the mortality, definitely it, I would say, the overweigh the risk of developing diabetes. So I, for one, would give statins if it is indicated. Will take care of the diabetes with other measures. Statin-induced hemorrhagic stroke was one picked up in the Sparkle trial. The Sparkle trial is a stroke prevention by aggressive reduction of the cholesterol levels, where more than 4,700 patients were studied for the embolic stroke, which was reduced significantly, the p-value of 0.008, but there was a very small risk of hemorrhagic stroke. So subsequently, they found out that there is a definitely risk of patients who had earlier development of CV stroke. It's better that we avoid statins unless it is indicated, and we be all the time on lookout for it. We have got now better drugs like PCSK inhibitors and ezetimibe. So maybe these are the drugs which are not prone to any higher incidence of hemorrhagic stroke. So maybe these are the drugs which we prefer if the patient has past history of hemorrhagic stroke. That's all about the statins. Then second is the ezetimibe. Ezetimibe is a wonder drug, and this is the drug which has definitely different mode of actions. It's known as a selective cholesterol absorption inhibitor. Cholesterol is absorbed at the intestinal border by a protein facilitated, which is called a Niemann-Pick C1-like protein, or NPC1L1. This is the protein which helps in absorption of the cholesterol in the intestinal border. And when ezetimibe is used, we do not have any effect on the fatty acids, bile acids, and fat-soluble vitamins. So we do not expect any such deficiencies of this even ezetimibe we use. Important part is that the ezetimibe can bring down the cholesterol absorption by as much as 50%, and the plasma LDL-C reductions by 20%, which is quite a substantial number. That is why the point I mentioned earlier is that going from 10 milligram of rosuvastatin to 20 milligram would expect the LDL to reduce by 5%. While if you use ezetimibe and rosuvastatin or atorvastatin, probably will bring down much more. Second thing is, it is assumed that once we use, it has been observed that when we use atorvastatin or rosuvastatin, the liver synthesis of cholesterol is reduced. So there may be some increase in the absorption of the cholesterol at the intestinal level. And that is why it is better that we use now atorvastatin or rosuvastatin with ezetimibe, so that we take care of the both. Ezetimibe is a drug which we cannot give in pregnancy and lactation. For that matter, statins also we cannot use in pregnancy and lactations. And patients who have active liver disease of moderate to C, that is childhood class B or C, we better avoid it. And children, it has not been tested, so we cannot use it. Ezetimibe The advantage is its action is very fast compared to lipid profile reductions, lipid reductions by the statins, which requires anything from 4 to 6 weeks or 8 weeks, while ezetimibe can bring it out much earlier. It has a very simple dosage, only 10 milligram, and very long half-life. It can be taken with or without food, while some of the statins we have to take in the evening hours. This can be taken any time of the day, and it can be combined with statins as well as bempedoic acids. And in fact, it is found to have a synergistic effect. And minimum drug-drug interactions. Most of the side effects are very marginal, or like abdominal pain, diarrhea, or flatulence, and they go with continuation of the treatment. There have been increase in the transient increase in the levels of enzymes, but only in less than 1% of the patients. And rare cases of cholestatic hepatitis and autoimmune hepatitis have been observed. So it's not that when we use these drugs, we do not look at the lipid liver functions report. We have to keep monitoring the liver functions periodically. Another important addition in our armamentarium is bempedoic acid. Bempedoic acid is a drug which works in the liver, as we discussed earlier, but it works in the cholesterol synthesis pathway as a step ahead of the HMG-CoA pathway. As we can see in this cartoon, that this is the work which works at the conversion of citrate to ATP citrate lyase, which is before, almost 3 steps before the HMG-CoA, which is the cholesterol synthesis pathway or cycle step. So this is a drug which works in the whole process of cholesterol synthesis much ahead of the HMG-CoA or cholesterol productions, but it's a poor drug. It gets activated only in liver. The advantage of each that the muscle are not affected. These drugs does not affect any cholesterol or these side effects of muscle. So that is why this particular drug, bempedoic acid, is very safe as far as the patients who are having side effects of statins, in statin intolerance or non-responders. Bempedoic acid is a welcome addition. Few things we have to remember about bempedoic acid. It reduces the LDL by not as high as statins, though comparatively it's less potent. It's hardly around 20%, but it also reduces ApoB levels. That's a good part. And we have to keep in mind that patients who are already having a high uric acid or known patients of gout, you have to be careful because it can increase the uric acid. It increases the uric acid because of its metabolite works at the kidney level, at the kidney levels, and interact with uric acid and decrease the absorption, increase the absorption of uric acid, and that is why it is increasing uric acid. Not that uric acid production is increased, but it does affect, can bring about the acute attack of gout. So you have to be very careful, patients who are already having high uric acid levels or gout. And it can produce tendon rupture and even tendinitis. But again, these symptoms have been found more in patients who are receiving bempedoic acid at the background of statins. So patients who are taking statins and bempedoic acid, the chances of tendon rupture are more. The dose is fixed, like ezetimibe is only 10 milligram, bempedoic acid is 180 milligram daily, and it can be taken with or without food. We don't need to adjust any dose till the eGFR is 30 ml per minute. Now comes the newer drugs. Of course, these are drugs now which are available and they are very important, and in fact, they are the direct results of the study of LDL receptors and drugs are the substances which are used in the LDL receptors metabolism. So PCSK9, which the full form is proprotein convertase subtilisin caxin type 9. We don't have to use that word again and again. It is just PCSK9. It is a protein. It is a protein that targets the LDL receptors for degradation. So with the help of PCSK9, the LDL receptors are degraded. So if the PCSK9 is more, the LDL receptors would be less. If the LDL receptors are less, the LDL will not be removed, because LDL receptors, the only function is that it removes the LDL from the blood and bring it to the liver. So PCSK9 protein, it's one which works on the LDL receptors. And if you have got a PCSK9 inhibitors drugs, right, it will reduce the PCSK levels, which will increase the LDL-C receptors level, so cholesterol will be reduced. There are two drugs which are available. One is evolocumab, another is alirocumab. Both these drugs are the monoclonal antibodies. The alirocumab is a drug which is available as 75 milligram and 150 milligrams. These are the screenshots of drugs which are available in the Indian market in the India Mart stores. And the cost is approximate. It may change the time you ask for it, but roughly around the same. So 75 milligram of alirocumab is going to cost around 4,000 rupees, and you have to take 75 milligram 2 weekly. So twice a week. So 2 dosages of the 75 milligram of alirocumab or 300 milligram every month. But this is practically this abundant. So only drug that right now is mainly is the 75 milligram every 2 weeks. So that would come to around 8,000 rupees a month. Just the not many side effects. There are some hypersensitivity reactions and angioedema for which we have to be careful in the initial few dosages. But otherwise, the side effects are flu-like symptoms, influenza-like illness, and injection site reactions. But otherwise, very safe. It has been used for over 2-3 years over a period of time and have a consistent results of bringing down the LDL by more than 50%. The evolocumab is Repatha, again available in 140 milligram strength only, and the dose is 140 milligram, which is these are all to be given subcutaneously, and this is available with a special injector called auto injector or called Sure Click. So this is a drug which is around 20,000 rupees per ampule, and this has to be given every 2 weeks. Those nowadays 420 milligram dose is abundant after the June 24, but when it to be given, we have to use 3 140 milligram subcutaneous and 3 different sites on the same day. But here now we use only 140 milligram every 2 weeks, and the cost is around 20,000 per ampule. Again, side effects are few like hypersensitivity reactions, angioedema, and local side effects, but it also can increase the blood glucose levels. Another important class of drugs are called inclisiran. Inclisiran is a drug which is called a small interfering RNA, siRNA. siRNA are the ones which interferes with the production of intracellular PCSK. As we have said that if the PCSK is less, the LDL receptors will be more, and that is how it will remove the LDL from the blood. So it directly reduces the production of PCSK9, and that is how it works. A wonderful molecule, and the beauty of it that we have to give it on a very few doses. So it's also called as lipid vaccines. Inclisiran is being promoted as a vaccines because we have to give only 2 dosages. We'll come to that, and it reduces the LDL reductions by as early as 40 days post dose. First dose, after first dose, almost after 2 weeks, we can see the effect of the LDL reductions, that too to the tune of 48 to 51% in another 30 to 60 days, and it has persisted for more than 6 months. 50% reduction is persisted for 180 days, and that is how it has to be given twice a year, except for the first time when we give inclisiran, which is available as Leqvio or Simbrava. And we have seen even the prescription of some of the cardiologists being prescribing these drugs. The first dose you give at a particular time, which is 284 milligram, again subcutaneous injections. The second dose is given after 3 months. Then every 6 months we have to give the dose. So inclisiran can be given after the first year every 6 months, but the cost is prohibitive. It's almost 1.1 to 1.2 lakhs per injections is the cost. Another drug is a lomitepid, which is now this is a drug which is not working on the statins pathway. It works at the microsomal triglyceride transport proteins. The microsomal triglyceride transport protein is the one which is produced in the endoplasmic reticulum, and that is the main important substrate for the apolipoprotein B, and that is how it reduces the ApoB, VLDL, chymomicron, and LDL down the line. Important part is this is a drug which is orally available. So it's an oral drugs, 5 milligram, which we have to keep on increasing the dose. And important thing is that when we give these drugs, person should be on a low fat diet and should be given 2 hours after the dinner. Again, not many side effects except for the flatulence and some GI disturbances. Again, available as around 1000 rupees a tablet, and the dose has to increase from 5 milligram to 20 milligram, not exceeding 40 milligram. Again, it's available as a prescription medicine only with the import license authorities. I'm not sure, we haven't used these drugs, but it's available on the net at least. The mipomersan is the last drug in the pipeline at the moment, and this is an antisense oligonucleotide, or what we call as an inhibitor, ASO inhibitor of apolipoprotein. This is a drug which reduces the formation of ApoB, and that is how it decreases in the production of not only ApoB, LDL, but also LPA. Last time when we discussed lipoprotein A, which the structure is like lipoprotein LDL, but it's also got an additional ApoA, and that makes it more prothrombotic. And LPA is something which, except PCSK and mipomersan, no other drugs are reducing the LPA levels. And LPA itself is an inheritable risk for atherosclerotic cardiovascular disease. So mipomersan is another drug which, once the patent is over, it would be affording to most of our patients. Very long half-life, but it has a presently the black box warning of hepatotoxicity, and other side effects are not important. It's available as Kinamro. It's 1,65,000 as the cost for a 200 milligram, which you have to give once a week. So it is one of the most expensive drugs for the cholesterol reduction. So these are all the drugs that are available or available through the import license. So concluding my talk, dyslipidemia is a major cause of atherosclerotic cardiovascular disease and mortality. Many young lives are lost every minute due to underdiagnosis and under treatment of dyslipidemia. अभी तो देर है, बहुत दूर है. That's not something we should be. We should be very proactive and very aggressive while coming across any patients with high LDL cholesterols. Lipid-lowering drugs have proven their efficacy beyond doubt, and they are very safe. The primary target remains LDL-C. The non-HDL-C is now considered as a co-primary target. That means we also have to look at the total cholesterol minus HDL, that is the non-HDL. And statins remains the first drug of choice, but patients who do not tolerate statins or who do not meet the target with highest tolerated dose should be offered ezetimibe, bempedoic acid, and even PCSK inhibitors. The newer drugs can bring down the LDL level beyond 50%, and newer molecules are coming in the pipelines, and maybe we'll see someday the drugs. Thank you. So we'll be happy to have any questions and answers. I can see a few of the questions. In two of the questions are already there in the our flyers. And then one of the questions by one of the doctor was that how long we should be taking the statins. Statins, if they are indicated, we have to take it indefinitely, lifelong, obviously, because these are the drugs which work on the metabolic pathway, and the moment you stop the drugs after a few days, obviously the effect will be off. But we can stop statins for the time being in certain situations, like if the patient becomes pregnant or patient is breastfeeding, surely statins should not be given. Statins are big no for any patients who are pregnant or likely to be pregnant or who are breastfeeding. And patients who are taking other drugs like anti-TB drugs, if they have to take and they have developed some side effects, hepatotoxicity, or we need to take the TB drugs first, then maybe we can temporarily withhold statins. Likewise, if the patients are on HIV drugs and there are side effects, we can withhold statins. And if patients who already have some chronic liver disease, it's better we prefer non-statin drugs than the statin drugs. So that was one of the questions asked there. Yeah.
So for that wonderful talk. There's a lot of doubts coming in from our doctors.
Sure.
So we'll get started with the live questions. There was another question on the flyer
Yeah.
asking, can taking vegan food habits or nature's nutrients help to reverse hyperlipidemia or LDL cholesterol?
No. There are no such, because see, as I said, that practically the dietary contribution to the cholesterol is hardly 20-25% in most of the patients. So it's a 70% of the cholesterol is produced by the liver. That is one. And when we take cholesterols, it does bring about phytosterols. It is not cholesterol but phytosterols, and there is also phytosterolemia, that also its own effect. So practically being on vegan food would not make you immune to the lipid disorders. You have to attend the LDL cholesterol by way of modifying at their synthesis at the liver level only.
So, starting from one of the earlier questions that we had
Yeah.
from Dr. Kulkarni, at what minimum age and gender cholesterol and lipid profile investigation is to be advised to teetotaler candidates?
Right. So this was the questions which we I did not present this time, but we did mention in the lipid profile session that see if there is a family history of homozygous hypercholesteremia, right? Then it is better that all children are tested first in first 10 years, that is between 9 and 11 years, and then at the time of adolescence around 17 to 20 years. But at least that is what, if there is a familial hypercholesteremia. If there is no such history, I would say at least once they become the adults, so anything between 18 to 20 years, first lipid profile has to be done. Because as we have seen that the patient who has been having an homozygous hypercholesteremia or even heterozygous hypercholesteremia, their LDL would be anything from 300 to 600. So that load of cholesterol over a years would bring about the coronary events in the 30s and 40s. If we can bring down the LDL cholesterol earlier, if we are aggressive from the beginning itself, right, we can convince them. And some of the features on even examinations, like if they have got the xanthelasma, the lipid deposits over the eyes, or they were tendon xanthomas, right, or then or arcus senilicus, that are the features that we can suggest that probably they are suffering with the hypercholesteremia, or a one simple level non-fasting lipid profile itself would give the idea about the presence of homozygous or heterozygous hypercholesteremia. So I would say that at the first visit, or at least by the age of 18-20, we should get the first lipid profile levels. And those who have family history of premature atherosclerosis, young dates, or hypercholesteremia, or on treatment, maybe earlier. In the childhood itself, this would be screened for hypercholesteremia.
So, next, Dr. Naseem says, atorvas plus aspirin, can it cause subcutaneous hemorrhage?
I don't think that is because of the atorvastatin that the subcutaneous hemorrhage. Aspirin, yes, can cause, but then we do take into account the aspirin part of it, and then usually the thrombocytopenia is not a real issue. Aspirin does cause the mucosal bleeding in the gastrointestinal tract, but not in the hemorrhage. But we have seen patients or old patients who have got the I would say senile purpura, where we do find some subcutaneous hemorrhages, but not because of the combination of aspirin and statins. Statin per se would not produce the bleeding tendencies. Vitamin E preparations or those fatty acid preparations, they are sometimes associated with bleeding diathesis, but not the statins. None of the statins, as per my knowledge, are increasing the bleeding risk.
Another question from Dr. Akhtar was, is there any role of magnesium or vitamin D in atorvas induced myopathy?
Magnesium, I am not sure. Vitamin D, we have already mentioned that those who are vitamin deficiency definitely are more likely to have the myopathy, and it's better that we give vitamin D supplements to all patients who are on statins, because most of our patients would be deficient in vitamin D if you go for the vitamin D levels, or we can get the vitamin D levels and give it. But yes, vitamin D has a definite role as far as that absence or deficiency of vitamin D will aggravate myopathy. Magnesium, I'm not sure.
So next question from Dr. Patel. Why and how statins cause muscle toxicity in some patients and not in other patients, even though used in large amounts? And the second part of the question was, can the muscle-related toxicity of statins be permanent?
See, as we have discussed earlier, that why it occurs in some patients, it's there is no answer to that questions. But some of the patients who are on a higher dose, old age, right, vitamin D deficiency, these are the ones who are likely to get muscle toxicity. That is one, and it's the individual body's response. Stay muscles, all parts of the bodies produce cholesterol. Not that only liver. Liver does produce. So that is one thing. And the second thing is that what was the question?
Can the muscle-related toxicity be permanent?
See, as the per the literature, they are supposed to reverse once we stop the statins for 2 to 4 weeks. In fact, once the symptoms persist, we should look for the secondary cause of the muscle involvement, myopathy or myositis. Maybe we are missing some endocrinopathy like thyroid myopathy, or maybe we are underlying missing vitamin D or other drugs. But statins myopathy is not permanent, as I understand.
So next from Dr. Mishra, how to calculate average LDL level per year?
So this is that we have taken the LDL lipid profiles levels in 3 times, and if we see the LDL levels, then we see that what is the LDL levels for that particular year. That is considered as 1 year. Like that, we see the LDL levels, average LDL for that particular year, and it multiplied by the age, and that comes the total LDL load. So if suppose my LDL level, as we have given the example, is 100 milligram every year. Every time if I do it as one day it is 100, another time we do it 110, another time it's 90. So average it is 100. So my LDL, if it is 100 milligram a year, and if I am 70 years, then my LDL load would be 7,000. That 7,000 something that can bring about the acute coronary events. That is what the postulation is. So that's why you bring to less than 70, so that you can live for 100 years without atherosclerotic disease.
So next from Dr. Devra, Dr. Devra says important side effect of bempedoic acid is rise in uric acid levels. High levels of uric acid has been associated with increased risk of MASLD in non-obese young individuals. Your comments, please.
No, the first part I agree. The second part I am not really very sure about it. About probably there are more associations than the cause and effect relationship as far as the MASLD is concerned. Uric acid level, we already discussed that definitely bempedoic acid is interferes with the what is called OATP2. That is one of the protein that is at the metabolite that works at the distal kidneys level tubules. That is where it prevents the uric acid absorption, and that is how the uric acid levels are increased in the blood. It's not that uric acid production is more, but the excretion is less because of the side effect of the bempedoic acid drug interactions like that. But uh, I am not sure about the MSLD and the association of uric acid levels. But all said and done, we have to be careful when patients on bempedoic acid. Before starting, we should get the uric acid levels, and you have to be very careful when patient is also on the drugs like statins, so that the tendency for the tendon rupture or tendinitis will be more likely. So we have to be on move, and if required, the literature says that you can give the drugs to bring down the uric acid levels in such situations. But that could not be the only reason for bringing down stopping the bempedoic acid if it is useful. We can use uric acid lowering drugs along with bempedoic acid.
Next, Dr. Purnima asks, in a man of 40 detected dyslipidemia for the first time, how should one choose the medicine, statin or ezetimibe?
See, ezetimibe is a good drug and a safe drug, but it does not bring down the LDL cholesterol to the more than 15 to 20%, 20%, right? So if our starting LDL level is high, and if we want to bring it out to say 50% or the 40% of the baseline values, somebody's LDL cholesterol is say 130 or 140. If you bring down to less than 100, we need a potent drug, and the potent drug is statin. And that too the right dose. If I have to use atorvastatin, I would give 20 milligram. I have to use rosuvastatin, I will use 10 milligram. So moderate dose of statin should be started. And age is, as I said, is not an criteria. Criteria is the LDL cholesterols. Earlier it used to be the age, but now that focus is on LDL. If the LDL is high, bring down LDL and sustain that lower levels for a long time to prevent the events. So at 40 also, I would definitely start. In fact, we have started even 25 years, except the women patients where you have to be careful where during the period when they are likely to conceive and the breastfeeding time. Otherwise, statins should be continued.
So next, Dr. Sadananda says, so when do we start this lipid lowering agent? For example, do we have to start statins when the LDL cholesterol is more than equal to 160? And the same question goes for triglycerides also, or is there a specific cutoff for starting the treatment?
See, there are different associations have given different criteria for this, right? If the LDL cholesterol is more than 190, all the associations say that you have to start this. If it is less than 190 but more than 160, and if there are other risk factors like the premature family history of premature ASCVD disease or patient is diabetic, those factors would make it. But I'm sure that everywhere the bringing down the LDL has to be under 100 minimum, right? Now, if I happen to see the patient first time, whether it's a 150 or 160 or 140, I'll first assess the diet part and I'll give them 3 months to observe their whatever oral fat that they can cut down, whatever weight that can reduce, whatever lifestyle they can change. We can reassess after 3 months. If there is not much change, it's time that we start. Even at 130, I will be starting the statins, definitely. It's not only 160, even at 130, I would start. My goal is to bring down to less than 100. That is for sure. Triglycerides, that's not the case. Triglycerides probably can bring down with good drugs, but triglycerides are related to our carbohydrate intake. If the patient is diabetic, control of diabetes, and the lowering the triglycerides have not proven equally to be translated into the cardiovascular mortality reduction. So triglycerides, we have to initiate the treatment for other indications of pancreatitis and gallstones. So if the triglycerides remain persistently above 400 milligram, definitely we need to treat that triglycerides for other indications. Otherwise, we need not start it. But if the triglycerides remain above 200 milligram in a patient who is already on statin, I can still think of adding that drugs, because as we discussed last time, that triglycerides, when they are more than 100 to 150 milligram, the triglycerides are converted into LDL. The LDL component from the triglycerides is different if it is triglycerides levels are 100 or 200. The persons who triglycerides are 100 will have more large buoyant LDL, which are not likely to get oxidized and go stick to the intima. But LDL, which is small dense LDL, which is more likely to cause the atherosclerosis process. So that is why triglycerides also need to be attended, but more with the diet part, number one, control of the diabetes if it is there, and even our statin drugs, they also bring down the triglycerides. And after that, if it persists, then only we have to think of adding the drugs for triglycerides. For triglycerides, I would not be starting the treatment unless there is another indications like for preventing pancreatitis or gallbladder diseases, and that too above 400 milligram.
So, taking the next question with quite some of both. If patient is newly diagnosed with cholesterol 235, which drug is the best, sir?
See, all said and done, the first drug has to be statin because it is tested, proven, efficacious, and also inexpensive. See, if you for somebody's having cost is not an issue, the obvious temptation would be to use PCSK, but they are approved over and above statin therapy. So statin remains the first drug of choice. Here with the 235 milligram, we would be definitely starting with at least moderate to high dose of statins like atorvastatin of 40 milligram or rosuvastatin 20 milligram to begin with. Maybe this is a drug which after 3 months or so, these patients, we might add ezetimibe. We might add even bempedoic acid. So this is how the sequence goes. First statin, then statin plus ezetimibe plus a bempedoic acid, and then we may go for the PCSK inhibitors or inclisiran.
So, sir, I'm taking the next two questions together.
Yeah.
One says if there's any association of a statin with cataract, and the other one says can statin cause tendinopathy?
Statins and cataract, not that I know, right? Tendinopathy, again, no, big no. It's mainly with the bempedoic acid that we have seen this, and when there is a combination of bempedoic acid and statins, we do find tendinopathy. But statin alone, I am not sure about the tendinopathy. There are side effects which are extremely rare, maybe there, but they are not one of the common side effects. Sure.
Next, Dr. Parik says if hereditary lipids are high, should we go for imperial statins?
Yes, definitely.
Next from Dr. Agarwal, if HDL-C is on a lower side and the other components of lipid profile are normal, what should be the line of treatment?
Yeah, that's HDL we have not touched, because in fact nowadays the HDL is losing its importance as far as increasing the HDL level for two reasons. HDL itself is a very heterogeneous molecule. There are HDL within HDL also there are good HDL and the bad HDL. HDL3 is good, HDL2 is not good. So we don't do routinely the HDL sub classifications. We do not measure the LDL HDL in different proportions contributed in whole HDL1. Second, HDL has got a J-shaped curve. That means very low and very high HDL are not good, and we do not have good drugs to increase HDL level. So all said and done, HDL is now not as important as LDL and non-HDL cholesterols. That's it. So because there are no drugs, the drugs which came into market also had to be withdrawn because of the side effects, and there is no potent drug. But yes, if we can increase exercise, if we can reduce the food, right? See, there are claims that if you use MUFA and PUFA like the nuts and the flaxseed oil and all those things, which will increase the HDL levels. But again, alcohol. Some people used to say that alcohol increases HDL levels, but again, all these things are not now out. And for practically for HDL, there is no drug. Some HDL is increased by the statins also, and some HDL increase in a small percent by even fibrates also. But still, we do not use for that indications. If we are using it for other indication and if it works, that's different.
So next question is also on similar lines. Can increase in HDL, which is brought by any drug, be cardioprotective? I have heard if HDL is increased by lifestyle modification, then only it is
That's true.
cardioprotective.
That's true. I agree. You echo my statement. Yes, it is.
So Dr. Agarwal says cost of all newer molecules mentioned by you is prohibitive, particularly in Indian context. So what is the future of such molecules in India?
You have to wait for the patents say to go patent. Otherwise, it's some companies have to come out with their indigenous molecules on the same lines. But statins, we have seen most of the time we are underutilizing the statins in the indication wise as well as the dosage wise. Ezetimibe is now quite affordable, right? Bempedoic acid is around 30 rupees a tablet, so roughly around 1000 rupees comes to 1000 rupees. But ezetimibe and statins, they would not cost more than 10-15 rupees, right? So and that can bring about the baseline LDL to at least 50% if you use the right drug. So that's substantial. So I think it's better that we start using them, right, rather than wait for the ideal molecule which can bring about 60% reductions.
So, sir, still there are a lot of questions. So
And
before proceeding, I would just like to
when
ask.
it comes to cost, only we are at the receiving end. But we see though those people, the same people, they spend like anything on the weekends or when they go out. So cost is probably more our inertia rather than we offer them, and I'm sure they are going to take it. If we say that if we take two dosages of inclisiran, right, of 2 lakhs rupees, so more people would come than what we feel. That's why I'm telling this, that now that we have started using semaglutide, which also costs around 300 to 350 rupees a day. And still, many patients are coming forward for prescription of these drugs. So it's not that so the patients uh, populations affordability is also increasing. Only thing is we have to convince them the need for this drug, right?
So before proceeding, I'd just like to ask if it's okay to take a few more questions.
Yeah, sure,
Because
sure.
there's So the next question I'm taking from Dr. Chaudhary. What are the non-drug measures to control LDL?
Non-drugs measures are, as I said, that see one of the important factor is the diet contributes to around 20-25%. So we have to bring down the diet in the form of the all fatty food, fry food. We have to cut down the weight. We have to increase the exercise. We stay away from the tobacco, alcohol, all that can add to the effects of the bad effects of the LDL, because HDL, one of the effect increasing is reduction by the tobacco. So that is how we can take care of it. Otherwise, I do not see that any specific food substance will bring about the LDL reductions. Only thing that is that you can take definitely the controlled diets in the form of the balanced diet, where is avoid high fatty fried foods, right? The fast foods, right? And take foods, even triglycerides also be reduced. So carbohydrate consumption will also go. We should increase our protein intake. We should maintain the exercise at least 150 to 200 millimeters minutes of uh, moderate degree of exertion every week, and look at the lipid profile levels. That's it.
So our next Dr. Javed says, when statins are stopped for any reason, shall these be restarted after lipid profile or without the tests?
See, it depends on why we stopped it. If you have stopped it because of the elevated liver enzymes or muscle kinase enzymes and CK enzymes, then definitely you have to wait for the normalization of the report, and then too we should not start with the same dose. You have to reduce the dose or change the statin. If the patient has altered liver levels, I would not give hydrophilic drug. I'll give a lipophilic drugs, and vice versa for the patients with the myopathic symptoms. So definitely we have to look for the indications, and only thing is, when do we consider as an abnormal report? So if the patient is taking any statins and if his SGPT or SGOT has increased by say just from 40 to 80, I would not consider it to be the indication for stopping the drugs, right? If it's only when they're more than 3 times the upper limit of the normal is there, then only we have to stop the drugs. Then we can re-challenge it, or we can look for whether there is any other drugs that patient might have been co-prescribed. See, one of the common antibiotic drugs, that is clavulanic acid, is more hepatotoxic than many of the drugs. Patients taking NSAIDs, paracetamol. So whether the patient has received drugs simultaneously, all that have to be accounted. If there is no drugs have been given, if the patient has altered liver or renal functions, definitely you have to stop the drugs and wait for the normalization of the reports, and then only start with a lower dose or alternative statins.
Next, Dr. Anand says, what are the safest lower level of LDL? In some patient, LDL levels are very low, even up to 10 milligrams without statins.
That's a very, very good question, ma'am. Definitely. The lower levels are considered to be around 30 milligram percentage. Levels lesser than that have not been tested, but patients who have got very low LDL levels, they have some reports of more colon cancers, dementia, and all those. So, if the patient is on drugs and the pharmacological, if you have brought down the LDL level so low, then definitely we should revise the dosages and bring to keep it around 30 to 40 milligram.
Dr. Purohit says, sir, is the ezetimibe to be given orally or subcutaneous? Also, if you want to stop statins, which other drug is to be started?
Yeah, so ezetimibe is an oral compound because it works at the intestinal levels. Its very action is at the cholesterol, selective cholesterol absorption at the intestine. So it is an oral drug, and when we stop statin, definitely the next best drug is ezetimibe, but it's not as potent. We have to keep in mind that it's not as potent as statin. So if our started baseline LDL is high, we have to give maybe probably ezetimibe plus bempedoic acid.
Next, Dr. Ashwin says, how can we manage statin dose in a patient on full dose ATT? Patient weight is 90 kilograms.
See, anti-TB drugs, not that all anti-TB drugs would produce hepatotoxic, right? We know that INH, pyrazinamide, and rifampicin are hepatotoxic, but not that every time we develop probably 5 to 10% of the patient would only develop the hepatotoxicity. So, if the patient is on statin and anti-TB drugs, and if he develop altered LFT, I will stop statin for a few days definitely. No question about it. Statins can be stopped for, that's what we said to begin with, that if we stop statin for a few days, that's perfectly all right. Instead of patients going into the hepatic toxicity, cholestatic jaundice, and many other complications, stop statin for a few days and look for the what particular cause could be the amongst the ATT drug is the responsible. We can start the anti-TB drugs also one by one and see how long he tolerates. What we have seen in practice that the same anti-TB drugs which has caused hepatotoxicity, once they are re-challenged, probably they tolerate it. Most of them. So that's not the case. Many times the drugs, it's an idiosyncratic reactions coming only for the first time, and we do not see it the second time. But that is all on regular under medical supervision. Statin can be stopped when the patient is on these drugs for a few days, definitely. question of weight doesn't arise. Question of weight comes only for the anti-TB drugs. For statin, it's not the weight that decides the dose, it is the LDL levels that decide.
Next, Dr. Vaishali asks, can omega-3 fatty acids help to reduce LDL?
Omega-3 fatty acids definitely reduce LDL level, but they are more often used for bringing down the triglycerides, right? And now that we have got a better drugs, and all the trials with omega fatty acids have mixed results. Some of them did show that reduction in the LDL, reduction in events, but majority are not in favor of giving it drugs. The only drugs amongst the omega-3 fatty acids is the icosapentaenoyl ether that is been shown in a trial called reduce IT trial, but the dose that gave was 4 gram. And but subsequent trial in the next year came that is called the strength trial, and that did not show that it is good. Maybe they use a little different compounds, but all in all, the omega-3 fatty acids for reducing the LDL is not something proven beyond doubt.
So the next is from Dr. Rawat. If the patient is alcoholic and LDL is normal and triglyceride is 249, what should we do?
Right, this is that alcohol itself is definitely one of the, we did not mention about it, but yes, alcohol is one of the things we have to keep in mind when we are treating the patients with statins. Right. Now, 249 triglycerides, maybe as a part of many alcoholics, they use the what we say along with the bites. In bites, they take a lot of cheese and a lot of the fatty substances. So that is what one you have to see the diet part. Second thing, whether they are diabetic, and if they are diabetic, the triglycerides, because of that, they may have pancreatitis. So I would be careful in definitely 249 is a not normal value for patients with alcohol. And if the patient's diet is taken care of and still the triglycerides are high, I would definitely start the treatment for the triglyceride patient because they have very high chance of developing pancreatitis and gallstone diseases.
Um, so this is also again on similar lines. If all lipid profile is normal and only triglycerides is increased, which drug should be the best associated with fatty liver?
Right. So again, as I said, the fatty liver, it's unlikely that these other lipid levels would be normal. But all said fatty livers, first we always take care of the weight reductions. Insulin resistance is one of the important contributing factor to which the important cause is the overweight. So weight reductions, exercise, diet, and after that, what levels of triglycerides we are dealing with. That's important. Whether he's diabetic or not, whether he has other features of metabolic syndrome or not. But if there is triglycerides and cholesterol both are high, definitely statin is the drug. If the cholesterol levels are normal and triglycerides are high, very high, definitely we attend the triglycerides because these drugs like fibrates, they do bring about the LDL also to some extent. And the fibrates definitely are the drugs to be preferred in NAFLD. One of the drugs is whether it's a gemfibrozil or fibric acid, these what we bezafibrates or the gemfibrate, they are all drugs are available. And saroglitazar is also one of the drugs for specifically about triglycerides and NAFLD. It's have been officially approved for NaSH in India. NaSH.
So sir, we can take the last 2 or 3 questions from the audience. So the next would be from Dr. Ahmed. Criteria for selecting atorvo to rosuvastatin.
Right. It's probably more of an individual preference for the drugs because if you use the right drug, right dose, that's important. Atorvastatin, rosuvastatin both bring down the statins, but at what dose? Atorvastatin we have to give little higher dose than the rosuvastatin. But if the indication is only high cholesterol levels, you can choose either of them. If the patient has altered say liver problems, I would prefer atorvastatin. If the patient has renal problems, I'll prefer atorvastatin, like that. So that is all that you have to see. Otherwise, there is nothing much to choose at the equipotent dosages. And the cost, so many factors that come in the patient preference, cost. If the patient's food habits are such, I would prefer to give atorvastatin in the evening and rosuvastatin any time of the day. So if the patient has to take these medicines at a particular time and that's not convenient, we may change the molecule because of that also.
So next is from Dr. Josephine. Polymyositis patient, what medication can be given for total cholesterol of 325 and triglyceride of 456?
So the issue is that whether these levels, and we have to look for the what is the cause of polymyositis, whether it's a part of the some other syndromes or SLE or these things. We have to attend that, and cholesterol levels and triglycerides levels and polymyositis need not be the under for one reasons. And these very high levels of cholesterol triglycerides, we would definitely start with the treatment of statins only first by all means. Only thing is we have to look for the liver enzymes levels as well as the creatine kinase levels, and we have to follow severely them, take care of the lifestyles, and urgently we have to look for the cause of polymyositis, whether it's a part of some paraneoplastic syndrome or whether it's a collagen disease, and treat that also. And parallelly we have to bring down the cholesterols and triglycerides. Triglycerides are here on a higher level, so we may be starting. It's not that we cannot use statins and fibrates together, we can use it, only the chances of toxicities are high. We have to be on high alert for that. We can use these drugs.
So, doctors, in the interest of time, we are going to be taking the last question for tonight. However, if you feel like your question hasn't been answered, you can definitely go post it under the flyer on the Medflix app, and we'll definitely pass it on to the speaker and get it answered for you. So, taking the last question from Dr. Jagjit, does the use of statins increase coronary artery calcification?
Yes, that's a very good question. Yes. See, basically, it makes the, but that is only as far as relations to the coronary artery calcium score is concerned. If you are going for a patient, substituting the patient for a coronary artery calcium scoring, keep that in mind that patient is on statins, you may get a higher score. Only thing is, if I have done somebody's coronary artery calcium scoring last year, and if that level was X, is on statin, at least now it should not increase. If it has increased in spite of means already on statins, that is a further progression of atherosclerosis. So it has a value only in that context, but we have to evaluate the coronary calcium score in relation to whether the patient is on statin. That is definitely yes, big yes. But any calcium score which is higher than 100 puts the patient on a higher risk, and we have to be on statin. So statins should not be stopped just because the coronary calcium score is. In fact, that's an indication for the uh, starting statin therapy.
So that is it for the question. And thank you
Thank
so
you.
much for taking so many questions very patiently. And doctors, like I mentioned, if you feel like your question hasn't been answered, do post it under the flyer, and we'll definitely try and get it answered from the speaker. So once again, thank you so much for this wonderful session. It's always a nice time having you. I hope you had a great time. Thank you
Thank you.
so much.
Yeah. This is very. I'm very, very happy that so many interactions and so many people still at the end of the long session are attending. Thank you. You
Thank
can
you, sir.
suggest the other topics also for our viewers. You can say that whatever topics they need to discuss, right? For from the internal medicines for our other guests also, we can get the speakers and the topics they can suggest on our platform.
Yeah. So, doctors, like sir mentioned, if you have any topic suggestion or any speaker suggestion, you can definitely put it up on the comment box and we'll definitely have a look at that. Thank you once again for attending the session. Hope you all had a great learning time today. Thank you once again, doctor, for attending, and thank you, sir. Have a good night.
Thank you. Thank you. Good night.